So my name is Hawkins Gay, and I'm an electrophysiologist at Northwestern Medicine in Chicago. I'm also one of the social media editors at the Journal of Cardiovascular Electrophysiology. Today I have the pleasure of speaking with Dr. Jared Bunch, who's an electrophysiologist at the University of Utah. And we'll be discussing a paper completed by Dr. Bunch and some of his colleagues featured in the JCE regarding the impact of rhythm control for atrial fibrillation. Dr. Bunch, if you don't mind giving a brief introduction to your background for our listeners, I can introduce the paper a little bit more and get started with questions.
Sure. No, thank you again for having me on and to be part of this and part of really a great journal. My background, I'm an electrophysiologist at the University of Utah, and I've been here about 5 years. Before that, led heart rhythm services for Intermountain Healthcare, that medical arm, for about 15 years. Had a long-standing interest in atrial fibrillation, and particularly its outcomes as they relate to brain health, stroke, function, and was part of CABANA early on when we tried to begin to understand how we treat it with contemporary therapies, can we really start to impact heart outcomes? And so those have been sort of indwelling research interests I've had over the past 2 decades.
Excellent, thank you. Well, I'm excited to hear more from you about some of this, but the paper specifically is titled Mortality Benefit with Atrial Fibrillation Ablation, Impact of Normal Sinus Rhythm Seen in CABANA and EAST AFnet. To start this paper, you give some background on the adverse long-term effects that are associated with atrial fibrillation. And I think a lot of folks are well aware of the risk of stroke, and that's, a lot of discussions that many of us have with patients. But you discuss a lot more than just risk of stroke in the beginning of this paper. Can you give us a little overview of some of the other potential negative consequences associated with atrial fibrillation?
Oh, for sure. And when I was the upfront, atrial fibrillation is so associated with a significantly higher risk of both cardiovascular and total mortality. And there's studies that have explored mechanisms of both. And when we started to look at this at Olmsted County when I was a fellow, the mortality rates with fibrillation after you're diagnosed with atrial fibrillation were very equivalent to many of the cancers that we consider to be quite aggressive and mortality associated. And so we've known for a long time that people that develop atrial fibrillation are on this trajectory of a higher mortality that's in excess of the majority of them will be dead at 5 years. It's over 50% at 5 years. So that's one thing. It's now also very well recognized. It's associated with heart failure with a reduced ejection fraction, but I think there's heightened awareness and a lot of interest, contemporary interest, on its association with heart failure with preserved ejection fraction. And then, of course, I have a lot of interest on how it impacts cognitive ability and how we process things, and it's strongly associated with dementia and Alzheimer's disease. And the nice thing with the brain, it's just a microcosm of all the organs, and so it's associated with renal dysfunction, pancreatic insufficiency. There's just a myriad of things that drive poor outcomes in patients with atrial fibrillation. And as some of this paper goes into how it affects our body as a whole, beyond just heart, brain, but our muscles, our pancreas, our lungs, our kidneys, everything that keeps us going.
Yeah, there really was a lot of information in there, and that was fascinating to me because, I spend so much time on stroke with patients, and I don't really get into a lot of the other potential negative consequences, which I think is really important, and certainly to patients themselves. And I think from my side of things, having more of a discussion about those consequences with patients to help inform their treatment decisions would be really important. It makes sense to me, for a lot of those reasons, that maintaining sinus rhythm would help prevent these consequences if they're indeed truly related or due to atrial fibrillation. There's some large studies in the past that, I remember vividly from medical school, that just did not seem to corroborate this. And, there were a few of these bigger trials that, everyone discussed as rate versus rhythm control. And it just they didn't show a major difference. And I was wondering if you could kind of give a brief summary of what those studies found and why, you think there may not have been a major difference in those trials.
Sure, and I think that's the natural question. We know atrial fibrillation is associated with all these adverse outcomes. What have we corrected? And how does that impact the natural history of the disease itself and the associated morbidity and mortality of it? And I think the most prevalent study and the most recognized study is the AFFIRM trial. And when we speak with our internists and our primary care providers, that trial still permeates thoughts of atrial fibrillation management more so than anything else. And that was a trial of, the average time from diagnosis of fibrillation to enrollment was multiple years, but it was really a trial of antiarrhythmic drug therapy, restoration of sinus rhythm versus rate control. And over time, the survival curves, and it was a mortality trial, were identical. And in fact, we saw higher rates of stroke in the rhythm control arm, driven primarily in those people in which anticoagulation was stopped. It didn't impact heart failure. It really was a neutral trial and led to the thought that we should just treat atrial fibrillation based on symptoms and not worry and use other means to lower these other risks. The question then was, well, maybe the patients weren't sick enough that sicker patients would benefit, and that led to the AF-CHF trial, which in patients with heart failure, again, really showed no benefit of all between the two. And those are the two largest trials. We go into some of the others as well, but we had the two most well-done randomized trials showing no benefit. But I think at that time, we had to keep in mind that these trials were never trials of sinus rhythm versus atrial fibrillation, because the efficacy of maintenance of sinus rhythm was very poor in these trials. Even though in the AFib-CHF trial, they received multiple cardioversions, they were on amiodarone, sotalol, and they did their best to keep them in sinus rhythm. The therapies were ineffective at that time to really maintain sinus rhythm. And rate control itself in the AFFIRM trial, a lot of people went back into sinus rhythm in the rate control arm. So we've had these trials of non-precise comparison of what truly means rhythm control, which we all think of, you're in sinus rhythm the vast majority of the time or all the time, versus a more lenient strategy where you go in and out of fibrillation.
Mm-hmm. Yeah, so maybe there just wasn't a large difference in the amount of time in sinus rhythm versus AFib between the two arms, and obviously you wouldn't expect that to show as much of a difference. So, certainly there are some newer studies now that have provided different results, and you go into, the specifics of two of these, even mentioned in the title of your paper. What do you think was different about these studies that is driving the difference that we're seeing in outcomes compared to the older ones?
And I think there's a few things, and obviously it's a disease, so it's likely going to be a multifactorial answer. But let's take EAST AFnet. This is a trial of early treatment, not necessarily ablation versus antiarrhythmic drugs. The majority got antiarrhythmic drugs early on in the trial and throughout the follow-up, but patients were identified within 1 year of diagnosis. And this was also a trial in which they had more effective monitoring rather than AFFIRM, when it was basically you come in with symptoms and you get an EKG. This was a trial where they were looking for subclinical and clinical arrhythmias. But what's interesting too is in EAST AFnet, it was rhythm control versus usual care in the setting of very comprehensive medical management. Their anticoagulant use was well over 90% throughout the duration. And I've run a prospective randomized controlled trial of anticoagulation, and we didn't have that adherence in the trial of anticoagulation. So that is really a tribute to the investigators and their care. The majority were on ACE inhibitors, statin therapies. This was comprehensive medical management in which rhythm control was applied early on. And in comparison, again, AFFIRM was multiple years after diagnosis, when a lot of the changes with atrial fibrillation may not be reversible. And really, for the first time, rhythm control won on mortality, on stroke, on sudden death. And they were able to impact really hard outcomes. Instead of making people just feel better, they were able to help them live longer and improve their quantity and quality of life. But what's interesting about that trial, and then there's also some discussion on the role of dronedarone, and dronedarone itself early on may be disease modifying. It was the one rhythm control drug in a sub-analysis of ATHENA that lowered stroke. And again, ATHENA was a relatively healthy population and a little bit closer to EAST AFnet than, say, AFFIRM is.
Mm-hmm.
But the authors went on, the investigators went on in the EAST AFnet trial to say really what drove the beneficial outcomes. And so they have a sub-analysis taking those patients that maintain sinus rhythm all the time. And the vast majority of the benefit was in not only rhythm control, but effective rhythm control. Maintaining sinus rhythm was a therapeutic target that resulted in the long-term benefit in that trial, whether it was subclinical or clinical recurrence. Maintenance of sinus rhythm was critical in that trial.
Mm-hmm. So potentially catching patients early allows us to be more effective with our rhythm control, and then, not throwing in the towel after, one option for rhythm control fails, potentially just trying pretty hard early on to do, we have different tools at our disposal now, may make a very big difference for these patients we're seeing early, it seems like. Okay. I did note that, not a lot of people in EAST AFnet, if I am looking at it correctly, received a catheter ablation. I think the majority of rhythm control for EAST AFnet was antiarrhythmic therapy. Do you see them as equivalent, or do you think there's a major role for catheter ablation in early AFib treatment based on this or other trials you've seen?
No, and I think that's a great observation. And, a catheter ablation with our current resource limitations really can't address the worldwide issue of fibrillation, and it's still going to be lenient a lot on drug therapy. But I think EAST AFnet tells us that if we engage early and we treat aggressively early, whether it's drugs or not, we can impact outcomes. Now, the population that got an ablation almost doubled over the follow-up, so people did tend towards that. And it gets to your point that, if, say, flecainide fails and we really want to still be aggressive about rhythm control, we can then bring in ablation itself. But we do know if you take on-surface medication, whether it's early on or a little bit later, and we'll talk about CABANA a little bit later, but early intervention, ablation versus medical therapy, ablation is just one. Every trial tends towards better outcomes. Arrhythmia-free survival, arrhythmia-based burden. All the trials have shown that ablation is more effective than antiarrhythmic drugs early on. But it is resource intense, expertise intense, not available all over, but it is the better of rhythm therapy, even early on.
Mm-hmm. And some patients also, don't want it in the beginning.
Exactly.
It's nice to know that there is effective, that the antiarrhythmic medications were also effective when counseling patients. And so CABANA, you mentioned, and also that was a study you looked at in the trial. That was a trial looking at catheter ablation, correct? What did you all find? Or you mentioned you participated that in the beginning, I think, and what did that really was? Yeah.
Well, and that gets at the second criticism of the early trials, is we were just not using effective therapies. So now we have ablation that's much more effective early on and long term. CABANA showed an almost 50% decrease in rhythm-free survival in antiarrhythmic drugs compared to catheter ablation performed worldwide. So CABANA really now is testing which strategy of rhythm control is better when you come in with fibrillation with one or two risk factors. And as mentioned, rhythm control is better. The primary endpoint did miss, and the primary endpoint of disabling stroke, sudden cardiac death, mortality, significant bleeding. It trended towards it being better with catheter ablation, and per protocol it was better, but there was never a question at all in CABANA which was better for rhythm. Rhythm management, arrhythmia-free survival was much better, whether you broke it up by burden, by first occurrence. Patients with catheter ablation have higher freedom from atrial fibrillation over time, and so it is a more effective therapy.
Yeah. And obviously, I think that's really important, when patients want to know what the likelihood of being able to keep them in sinus rhythm is when kind of counseling them. But, I really did enjoy reading the paper, and really appreciate you coming on and talking to us about it and your findings, and for your time, especially.
Oh, thank you. And the only one point left to make is what we found with CABANA towards the end, and this will be coming out in a full manuscript when we'd welcome people's interpretation and scrutiny, is when sinus rhythm was restored, we could see the same mortality benefit they're seeing in EAST AFnet, they're seeing in sub-analyses of AFFIRM. So sinus rhythm in CABANA was also a marker of improved survival, of less heart failure. But as you can imagine, and I think for the readers, for the listeners to think about, how do you define sinus rhythm over 5 to 7 years of follow-up for atrial fibrillation? So we have a paper that will be in press, and we'd welcome people's thoughts of how we tried to do it. But as you kind of think through it, it's not a black or white thing that you're either 30 seconds of AFib or more and you're in one group, or you have none and you're in the other group. There's a lot of people in between. So, but when we broke it down through different analytics, if you're in that predominantly sinus rhythm group, you just did much better.
And so that's coming out soon. And patients in CABANA were not within their first year, all of them, of diagnosis. Is that right?
Exactly.
So they had potentially AFib for longer.
And the other interesting thing about CABANA is even when you fail with ablation, your subtype of AFib changes. You're less, if you were persistent, you're often paroxysmal, long-standing persistent, often controlled on medicine. You tend to have a better and more healthy subtype. And that's another area of study, trying to understand what that means long-term in our patients' health.
Yeah, and I think there is a lot of evidence that catheter ablation, even if it doesn't fully control all of atrial fibrillation, it certainly delays onset of persistent atrial fibrillation, which can be really difficult for folks. So, well, again, thank you very much. This was really nice, and I really appreciate your time in coming along.
Thank you very much.